Today we will discuss cerebral malaria for SA. So this is the microscopic picture of Plasmodium. This is the mosquito that transmits malaria, female Anopheles mosquito. Cerebral malaria is a severe neurological manifestation of Plasmodium falciparum infection. It is defined as unarousable coma. It is fatal if untreated with a high morbidity and mortality. It is unarousable coma lasting more than 30 minutes in a patient with falciparum parasitemia in whom other causes of encephalopathy have been excluded. Causative organism Plasmodium falciparum, female Anopheles mosquito is the vector. Bite of infected mosquito is the mode of transmission. It is present throughout Africa, Southeast Asia, and also India. Highly prevalent in Odisha, Jharkhand, Chhattisgarh, and northeastern states. The host factors include young children under the age of 5 years, non-immune adults or travelers, pregnancy, especially primi gravida, immunocompromised individuals like patients with HIV or pre-existing malnutrition, lack of protective genetic traits. Coming to the parasite factors, high parasitemia, that is greater than 5% of RBCs are infected, virulent strains of Plasmodium falciparum EMP type 1. Coming to the environmental factor, poor healthcare access, drug resistance, and high transmission season are other risk factors for cerebral malaria. Coming to the life cycle, the sporocytes enter blood, then invade hepatocytes, and then release merocytes. The merocytes infect RBCs, then the trophocytes are formed, then scissions are formed, they rupture, causes fever, paroxysms. Falciparum infected RBCs develop a surface knobs containing PFEMP type 1, promoting cytoadherence to the vascular endothelium. So this is the life cycle of Plasmodium falciparum, where the sporocytes are released inside the human liver cells. They first replicate and release merocytes. From the merocytes, they enter the human blood cells. And from the human blood cells, they become trophocytes, scissions, and rupture, and then they in turn release gametocytes, and then they are picked by the mosquito. In the mosquito, they form gametes, oocyte, oocyte in the late, which is present in late mosquito stage, and again they produce sporocytes. So, mechanism of cerebral involvement. So, sequestration. Infected RBCs adhere to the cerebral capillary endothelium, obstructing microcirculation. Then rosetting happens, wherein infected RBCs bind the uninfected RBCs, worsening the hypoxia. This leads to endothelial activation, wherein cytokines like TNF alpha, IL-1, IL-6 increases vascular permeability and causes brain edema. Ischemia and hypoxemia are also caused. Oxygen damages, reduced oxygen delivery that damages neurons and glia cells. There will also be metabolic derangements causing hypoglycemia and lactic acidosis that aggravate the neuronal dysfunction further. Coming to the pathological findings in brain, there will be congested capillaries packed with parasite RBCs, that is plugged vessels, petechial hemorrhages, dark granulomas, and edema. In spleen, it will be enlarged, soft, and congested. Upper cell hyperplasia and fatty exchange. Kidney, there will be tubular necrosis and pigment nephropathy. So, symptoms of malaria: central, there will be headache, fever, fatigue, muscle pain, and back pain. There will be chills and sweating, dry cough will be there, splenic enlargement will be there, and nausea vomiting will be there. Unarousable coma, which is the hallmark of this infection. Seizures are common in children. Abnormal posturing and decerebrate rigidity is present. Brisk reflexes, Babinski sign turns out to be positive. Retinal hemorrhages and whitening will be there. Papilledema in raised intracranial pressure. Severe anemia, jaundice, hypoglycemia, oliguria, and acute renal failure will be there. Pulmonary edema, shock, and metabolic acidosis will also be present. Coming to the investigation, peripheral smear, both thick and thin films confirms Plasmodium falciparum with multiple ring forms and high parasitemia. Rapid diagnostic test HRP2 and PLDH detects antigen of Plasmodium falciparum. CBC will detect anemia, thrombocytopenia. Blood glucose will be low. The renal and liver function test, there will be elevated urea, creatinine, and transaminases. CSF analysis, there will be normal or mild protein rise, no pleocytosis. Fundus examination shows retinal hemorrhages and whitening. Imaging in CT scan brain shows diffuse cerebral edema, loss of gray-white differentiation, and hypodense lesion due to ischemia and microinfarction. Occasionally, petechial hemorrhages in severe cases can also be seen. MRI brain is preferred in research or tertiary care where there will be hyperintensities in white matter, thalamic, and brainstem. Restricted diffusion in cortical and subcortical region indicates ischemic injury. In children, posterior circulation often is involved. Findings are often reversible with prompt treatment. Remember, so coming to the differential diagnosis, viral encephalitis, where there will be CSF pleocytosis and absence of parasitemia will be there. Meningitis, where neck rigidity will be present. Hypoglycemic coma, where there will be immediate reversal after glucose infection. And heat stroke, there will be dry skin, very high body temperature, and no parasitemia. Coming to the management. Emergency management includes securing airway, breathing, circulation, control of seizures in children, and correction of hypoglycemia. And starting the anti-malarial IV instead of oral is preferred. IV artesunate 2.4 mg per kg IV at 0, 2 and 24, sorry, 0, 12 and 24 hours. Then once daily for 7 days or until oral therapy is possible. Alternative is IV quinine. Loading dose is 20 mg per kg for 4 hours, followed by 10 mg per kg every 8 hours with doxycycline in case of adults or clindamycin in case of children or pregnancy. So this is the national guidelines published in 2013, where the initial parenteral treatment for at least 48 hours with quinine, artesunate, artemether or artether based on the area, and follow-up treatment with oral medication with quinine. And in case of northeastern states with age specific ACT, AL, or in other states it will be ACT SP for 3 days with PQ, primaprid single dose on second day. Coming to the supportive therapy, management of seizures using diazepam or midazolam, paracetamol for fever, elevator the head, mannitol for reducing the cerebral edema, transfusion of blood if hemoglobin less than 5 gram per deciliter, dialysis for renal failure, maintenance of fluid and electrolytes, and avoiding overload. Hourly vitals, GCS, and urine output are required to be monitored. Blood glucose every 4 hours and daily peripheral smear until there is a parasite clearance. Watch for hypoglycemia, shock, seizures, and anemia. Untreated, there is a high mortality of greater than 30 to 40%. With IV artesunate, it reduces to less than 10%. Children may have long-term neurological sequelae. Early diagnosis and supportive care are life-saving. So, in case of neurology, there will be epilepsy, hemiparesis, ataxia, or cortical blindness, and there will be memory deficit, poor concentration, speech or learning difficulty. There will be personality changes, depression and anxiety. Hearing impairment and motor weakness can also be present due to these reasons. The features of severe malaria. Cerebral malaria is one of the features of severe malaria, the others being repeated convulsion, repeated generalized convulsion, severe anemia, renal failure, respiratory distress, hypoglycemia, circulatory shock, impaired consciousness. Coming to the prevention and control, personal measures like bed nets, repellents, and long sleeves are recommended. Community measures like source reduction of malaria, fogging, and larvicidin. Chemoprophylaxis with doxycycline and mefloquine for travelers are suggested. Cerebral malaria is preventable neurological emergency caused by Plasmodium falciparum. Risk factors include young age, pregnancy, high parasitic load, and delayed therapy. Prompt IV artesunate and supportive care saves lives. Vector control and early detection are key for prevention. I hope you learned from this video. Thank you.